And I will stop there and introduce our next speaker, who is Dr. Romello Petrosian. So Dr. Petrosian is an instructor in medicine at Harvard Medical School. She's one of my colleagues in the renal division at Harvard Medical School. And in addition to being a faculty member and having a medical degree, she's a graduate of our Master's in Clinical Operations program. So she's also an expert in clinical operations. So Dr. Petrosian, thank you for joining us today.
Thank you so much, Dr. Tucker, and I'm very excited to be here and present the next talk, thank you so much, on stopping the progression of kidney disease and type 2 diabetes. So this is my bio. I do not have any disclosures. And the objectives of today's talk are going to be to discuss the typical and atypical presentations of diabetic kidney disease. We're going to look at factors that contribute to progression, the 4 pillars of management, and then the reassessment recommendations that have come around. So to start off, let's take a look at the KDIGO heat map that we have over here. And really this outlines the patients who are at greatest risk of CKD progression. The International Society of Nephrology and KDIGO guidelines provide this very useful landscape of eGFR categories that you see here on a vertical axis and albuminuria categories on the horizontal axis. And they together create this heat map, which gives you an ability to risk stratify the patients at highest risk. And patients at low-risk category may be followed yearly or earlier if they're developing new symptoms or risk factors. Patients in the moderately increased category should be followed at least once a year, if not more. And as we transition to our high-risk patients, those are the patients that should be followed up at least twice a year. And at very high risk, nephrology consultation is also very helpful. And these patients should be followed at least 3 times a year, if not more. So it really gives you an idea of when to set up follow-ups, when to refer, as we're trying to identify the patients that would benefit from intervention the most. So how does the heat map actually look when we're looking at this in the format of diabetic kidney disease? Well, the natural history of classic diabetic kidney disease was really conceptualized during an era of observational studies where we didn't have the same glucose lowering and blood pressure lowering treatments. Most of the patients were treated usually with insulin. So in our first category, the classic DKD, these are the individuals with diabetes, with poor glycemic or hypertension control who developed diabetic kidney disease, who presented with a relatively high eGFR, which indicated glomerular hyperfiltration. And it was really an adaptive response to nephron loss that would then be subsequently followed by persistent albuminuria. And development of the albuminuria tends to be rather unidirectional, transitioning from normal levels to macro levels, macroalbuminuria levels, usually about 2 years. And there's a steady decline of eGFR that you tend to see in these patients. In category 2, these are some of our patients with diabetes where the progression of albuminuria to normal albuminuria is not unidirectional, and there is regression that can also occur of the albuminuria. And this is also associated with improved blood pressure control, glycemic control, especially when you're using RAS inhibitors and SGLT2 inhibitors. So this is the category that you may see. In category 3, we see our rapid decliners. The annual rate of eGFR decline in patients who are healthy, that's mainly due to age-related structural changes in the kidneys, such as nephron loss over time, should be less than 1 per year. And patients with a very high annual rate of eGFR decline, which is more than 5, are termed as rapid decliners according to the KDIGO guidelines. And a rapid decline is thought to occur in patients with diabetes after an onset of macroalbuminuria, and it tends to rarely occur in those without albuminuria. And you tend to also see rapid decliners that may have non-diabetic causes of kidney disease. So it's also important to think of glomerular disease, interstitial nephritis, nephrosclerosis, for example, in these cases, where it's not just the diabetes that might actually explain the picture. And the final category, which is a proportion of individuals with diabetes who have a low eGFR without macroalbuminuria, meaning non-proteinuric diabetic kidney disease, or even without microalbuminuria, meaning non-albuminuric diabetic kidney disease. And with these patients, the prevalence of this phenotype, you tend to see it about 20% in patients with type 1 diabetes, about 40% in patients with type 2 diabetes. And the clinical factors that you tend to see associated with this phenotype are patients with female sex, with hypertension. They tend to be non-smokers. They tend to not have retinopathy present. And they're also typically using RAS inhibitors as well. And it's also important to recognize that retinopathy usually tends to precede albuminuria as a microvascular complication in diabetes. Typically, you tend to see it more so in type 1, not so much consistent in type 2. And it's also important to kind of remember that the size of the blood vessels that you tend to see in the eyes is about the same size of the blood vessels you see in the kidneys. So the complication of one with the other, that's the reason that they tend to go hand in hand with each other. The important mode of presentation that we tend to see with our patients is really patients who are coming in with an AKI, that are also taking NSAIDs. They might have cardiovascular events or septicemia. That's how the initial presentation sometimes may occur. And many patients may also lose the overt clinical manifestation of diabetes because of some of the CKD-associated weight loss that they may have, some impaired kidney gluconeogenesis, or there may be an increase in the insulin half-life. And some of the earlier changes that you'll see is actually an increase in the EGFR. So with hyperfiltration, you tend to see larger kidneys. If an ultrasound is done, that may be the initial sign of things. Then the next observable change would be the moderately increased albuminuria, 30 to 300 usually, sort of putting us at the A2 category on that KDIGO heat map. And that can progress to our severely increased albuminuria. And also, as I mentioned, the EGFR decline usually tends to be within those 5 millimeters per minute per meter squared while the patient is on a RAS inhibitor. And if you tend to see someone who is progressing faster than that, it's important to recognize that it may not be diabetes alone, or it may be a combination of diabetic kidney disease combined with something else. So in a pictorial presentation, this is what you tend to see in terms of the natural history and the pathophysiology of that nephropathy that we tend to see in patients with type 2 diabetes. And it's important to note that that period of hyperfiltration, the A1C improves during that period of time. And it may be really deceptive, especially since that's the point at which we're seeing the evolution of diabetic kidney disease really unfold. Patients with type 1 diabetes should be screened for diabetic kidney disease 5 years after they've been diagnosed. Patients with type 2 should be screened at the time of diagnosis because it's really difficult to determine when the patient developed type 2 diabetes in the first place, and a lot easier to really pinpoint that for patients with type 1 diabetes. So if we're looking at those two phenotypes that I've also mentioned, the non-albuminuric versus albuminuric diabetic kidney disease, this is what the studies and the meta-analyses have really pointed out that have been significant differences between the two, is that presence of more macroangiopathy that you tend to see in the non-albuminuric phenotype, and more microangiopathy that you tend to see in the albuminuric phenotype. There is more correlation with retinopathy in the albuminuric phenotype. There's more glomerulosclerosis, and patients of female sex tend to be usually in the category where they don't have albuminuria. And there is more correlation between albuminuria to A1C, and not so much correlation with A1C to the non-albuminuric phenotype. So why am I telling you this? Well, the reason is really this, is that there is a significant amount of uncertainty in terms of the diabetic kidney disease phenotype, and there is a higher cardiovascular risk that is seen also in patients who may not necessarily have albuminuria and may still have a rather significant cardiovascular risk. And the link between the two still remains poorly understood. So it's important to also recognize that these patients are not without risk, that there may be presence of endothelial dysfunction, maybe chronic low-grade inflammation that might explain some of these mortality factors, and kind of identify that there may may be also some transvascular leakage of macromolecules that might be contributing to their morbidity. And it's also impactful to look at the treatments that we've had over time in terms of really affecting the GFR loss that we've seen in our patients. Although the ARB trials in the early 2000s have reduced diabetic kidney disease progression to that eGFR loss of about 4 to 5 milliliters per minute per year loss, we really still have not normalized the rate of decline to less than 1 that we tend to see from age-related changes. And this is where the SGLT2 inhibitors came in. The development of the sodium glucose cotransport 2 inhibitors for hyperglycemia management and the subsequent results that we've seen in terms of the cardiovascular outcomes trials really led to this big paradigm shift in how we manage diabetic kidney disease and really looking at things from a cardiorenal perspective. When we look at the Credence trial, that was the first study that looked at the effect of inhibiting the primary composite endpoint of reaching end-stage kidney disease, doubling of the serum creatinine or a renal or cardiovascular death in over 4,000 patients with type 2 diabetes and CKD that were already on RAS blockade. And the trial was actually stopped early due to efficacy, we demonstrated about a 30% relative risk reduction in the primary endpoint, and really kind of started the story that we're seeing today. So to kind of identify the biggest RAS kind of inhibitor trials have been the renal and the IADNT trial. These were some of the 2 randomized trials that really supported the renal protective effects of losartan and irbesartan in patients with type 2 diabetes who also had albuminuria above 300. And again, demonstrating that there was reduction from the original GFR loss, but there was still significant residual loss that you're seeing as the area under the curve because of those studies. And when we look at the studies on glucose control, when looking to improve population health, there has really been several landmark studies that have come through in terms of managing diabetic kidney disease. When we look at 1987, the Diabetes Control and Complication Trials, the DCCT, there was a remarkable reduction from normal albuminuria to moderately increased albuminuria and microvascular complications, specifically retinopathy, when the study looked at patients who had tight glycemic control. So retinopathy was improved and albuminuria was improved. In 1998, the UK PDS study, this is where the reduction of the A1C level by 0.9% in patients with type 2 diabetes also reduced microvascular complications, which included nephropathy. Then we go into 2008 to the ADVANCE study, where the intense glucose control with a target A1C level of 6.5% was also associated with long-term reduction in kidney failure without evidence of increasing risk for cardiovascular events or death. Then 2015, the EMPA-REG study. This is where we saw patients with type 2 diabetes that were treated with empagliflozin and lower glycated hemoglobin levels. They had a significant reduction in cardiovascular and kidney events. And really the protective effects of SGLT2 inhibitors in this study were recognized to be beyond just a simple glycemic control. In the Credence trial, which I've already mentioned, the canagliflozin reduced the risk of kidney failure and cardiovascular events. Over 4,000 patients studied with type 2 diabetes. They had albuminuria between 300 to 5,000 milligrams per gram. They were followed for over 2.6 years, and these benefits were really consistent across the eGFR groups, which really meant that you could initiate these treatments really at eGFR levels as low as 30 in the Credence trial. When we looked at the DAPA-CKD trial, the goal went even lower, with eGFRs going as low as 25 in that trial. And dapagliflozin was found to confer kidney and cardiovascular protection in patients with type 2 diabetes, who also had albuminuria now going down to as low as 200 to 5,000 milligram per gram. Again, suggesting that the SGLT2 benefit wasn't just specific to canagliflozin itself, and it was more of a class benefit. And then even more recent, the EMPA kidney trial recruited patients going as low as a GFR of 20. and again demonstrated benefit of CKD progression. If you ask nephrologists, our clinical practice is to even continue SGLT2 inhibitors below the GFR of 20. And this is these three studies really combined together where you can see the, again, reduction of the kidney outcomes between credence, DAPA-CKD, and EMPA-Kidney. They all supported the benefit of reducing that residual risk, but at the same time, there's still presence of that residual risk that you see, which also was an indication that we need more studies beyond the ones that we've seen so far. So in patients with type 2 diabetes, another thing that happens is you get hyperabsorption of glucose and sodium in the proximal tubule. This tends to cause the glomerular hyperfiltration, which leads to glomerular inflammation and fibrosis. And when we use SGLT2 inhibitors, the way that they also work, besides the glycemic control that we've mentioned, is they increase the sodium concentration in the macula densa. They thereby constrict the afferent glomerular arterioles, and through this tubular glomerular feedback, there is a reduction in the hyperfiltration, which is one of the causes for why the kidneys are progressing and there's progression of nephropathy. So there's really a reduction in terms of the tubular work, the oxygen requirement, and they thereby reduce the damage that's associated with hypoxic tubular cells and enhance renal erythropoietin production. There is some degree of diuretic effect also, which is why they've been shown to be helpful in terms of cardiovascular protection. And they've made their way into the KDIGO 2024 recommendations that really push for us to implement SGLT2 inhibitors into reducing the progression, especially in patients at high risk. And even if they don't have a diagnosis of diabetes, but may also have heart failure or may just have significant levels of albuminuria that might put them at a higher risk of progression. So to further reduce the residual risk of CKD progression, we've also looked at GLP-1 receptor agonists. The SUSTAIN-6 and the PIONEER-6 trials, the mean annual eGFR slope was less steep in patients who were treated with semaglutide versus placebo, which indicated that there was a further reduction in the risk of progression of CKD. There was also a post-hoc analysis done that looked at the number needed to treat for semaglutide, especially in the high-risk patients, and that number was 7. So again, indicating that there was significant benefit associated with those medications. In patients with type 2 diabetes, when we're looking at stage 3 and 4 CKD, once-weekly dulaglutide also produced a glycemic control that was very similar to the one that was achieved with insulin, and also helped reduce the decline in GFR. So again, we're seeing more of that class effect developing with GLP-1 inhibitors as well. And this has made it into the guidelines here too. So with SGLT2 inhibitors that are nephroprotective, with their reduction in glomerular hyperfiltration, with the GLP-1 receptor agonist, decreasing oxidative stress, the TGF-beta-1 levels, and demonstrating that there is reduction of those pro-inflammatory macrophages in the kidneys. And the recommendation is to follow these patients, to start them on these medications, and to really regularly reassess their risk every 3 to 6 months as those medications are being added to their regimen. And in terms of the additional, the third agent that we haven't yet mentioned, the non-steroidal MRA, the inspiration to adding it really came from that recognition also of that high residual risk of CKD progression with the current therapies that we've had. So when you looked at the Credence trial as well, again, there was a benefit of adding canagliflozin together with the RAS inhibitors, and the reduction was evident in that group, but there still was presence of residual risk. And oftentimes, when we're thinking about mineralocorticoid receptor agonists, we're we're thinking about insurance coverage, the feasibility of that. And there's always a question as well in terms of, well, what is the difference between medications like finerenone, for example, and other steroidal MRAs? And the differences are highlighted here. And specifically, that you may notice that finerenone has a high potency and selectivity for the MR. And as a result, there are no sexual side effects. And the rate of hyperkalemia tends to be much lower with this drug compared to the other steroidal MRAs. And in the Fidelity pooled analysis, this is a study that pulled together patients from the Fidelio DKD and the Figaro DKD trial, which analyzed over 13,000 patients, which demonstrated that there was a significant risk reduction in cardiovascular events compared to placebo, and reduction in kidney composite events, especially in patients who had higher levels of albuminuria. These patients were followed for a median follow-up of 3 years, and there was also benefit in terms of cardiovascular outcomes that was noticed in finerenone compared to placebo. The composite kidney outcomes were also 5.5% compared to 7.1% in the group that was receiving finerenone. Finerenone compared to placebo, and the safety outcomes were generally similar as well between the treatment arms. Hyperkalemia that actually led to discontinuation of the drug was rather small. It was 1.7% compared to the placebo group, which had 0.6% of hyperkalemia. And again, pointing out that the screening for patients to identify those at risk who had higher levels of albuminuria with type 2 diabetes really facilitated that burden of having progressed kidney disease where finerenone could be intervened. And this was a subgroup analysis that looked at baseline EGFR groups compared to the UACR categories, the albuminuria categories, with patients that were treated with finerenone. And you could see that, especially in groups that had an albuminuria level above 300 milligrams per gram, the benefit was seen even higher, regardless of the EGFR group. So EGFR could be completely normal, and if the patients had albuminuria, they actually benefited from the addition of finerenone. With having type 2 diabetes. So the hazard ratios for kidney outcomes were directionally consistent across the baseline UACRs and EGFR categories, again indicating that finerenone was beneficial to slow CKD progression across the spectrum of severity. And the highest degree of uncertainty really came in terms of looking at patients who had normal albuminuria to microalbuminuria 30 to 300, and there was some uncertainty in terms of whether there was benefit there, but there was clear benefit that you saw in the subgroups with the UACR level above 300. So despite the availability of these established newer pharmacotherapies to delay our CKD progression in patients with type 2 diabetes, there still is a risk of progression, associated morbidity and mortality that remains substantial, and that inspired the FLOW study, which was a dedicated kidney outcomes trial designed to assess the kidney protective effects of semaglutide, which was a GLP-1RA, and its potential to improving treatment options in patients with CKD and type 2 diabetes. It's important to point out that this study also had a patient population with a significant CKD burden that really reflected the reality of what we're seeing, where 68.2% of the participants were deemed based on the KDIGO guidelines to be very high risk of CKD progression. And the prior analysis of GLP-1RAs, the SUSTAIN-6, the REWIND, the LEADER trial, they really focused on cardiovascular outcomes, and there was an indirect effect, such as improvement of glycemic control, weight loss, reduction of blood pressure, that couldn't quite account for the kidney protective effects. So this study was really dedicated to specifically look at the kidney outcomes, and there was a potential suggestion that maybe reduction of inflammation or oxidative stress could be contributing to some of the benefits that we're seeing. And FLOW was an event-driven trial. It was stopped early due to clear positive efficacy. There were over 3,000 patients that were recruited to this, and there was and the goal was to detect the likelihood of semaglutide at 1 milligram versus placebo reaching a 20% relative risk reduction to reach the primary endpoint. And these were the patients that were also followed for over 3.4 years. And these were patients who had type 2 diabetes with an A1C level that was less than 10, that were eligible to be included. They had a high risk of CKD progression. They were also receiving a stable maximal dose of a RAS inhibitor already. And kidney disease was defined as having a GFR between 25 to 75 mils per minute per body surface area, and with a urine albumin to creatinine ratio of greater than 300, but less than 5,000. And these were the patients that, again, demonstrate the efficacy that you could be adding a lot of these agents together. 15.6% of these patients were also on an SGLT2 inhibitor. So, and there was a benefit demonstrated. So this was to more of a demonstration that adding these agents together, combining these agents together, is really where we can provide the biggest benefit to our patients. And the primary composite, the outcome was major kidney event, which was onset of kidney failure, meaning either starting someone on dialysis or transplantation, if the GFR dropped below 15, or if there was a sustained 50% or greater reduction in the EGFR. And the number needed to treat over a period of 3 years to prevent one of those primary outcomes was 20 when we were looking at semaglutide. And this was at the 1 milligram dose that was seen in the FLOW study. So given everything that we know, unfortunately, albuminuria is often not measured in our patients. So in the cohort study, the CURE-CKD registry, where more than 2.6 million adults and children with chronic kidney disease or were at risk of chronic kidney disease were included, albuminuria, proteinuria was tested approximately 1/8 of the time. And RAS inhibitors were prescribed 1/5 of the time. And NSAIDs, or PPIs, that were associated with kidney injury were actually prescribed more than 1/3 of the time. So we have a lot of work to do. And identifying the patients at risk is really the first step of how we go about it. And prescription of guideline-directed medical therapy is also pretty suboptimal in our patients. So this is an area certainly of a lot of work, and with changing policies and coverage, this also is something that I could definitely see these percentages improving and rising. But it's important to also identify the fact that when we start our patients on these agents, oftentimes we discontinue them. And the discontinuation often happens because of this dipping effect that you may see. So the beneficial effects of RAS inhibitors, ACE inhibitors, ARBs has really been known for more than 30 years. And these drugs cause a 10 to 30% initial reduction in the EGFR when the therapy is initiated. You tend to usually see that drop within 2 to 4 weeks of starting the drug. And the initial drop in EGFR has really been a significant concern for many clinicians that remains today. And the actual mechanism for why the EGFR drops is not really known. Some suspect that it just may be a reduction of glomerular capillary pressure due to a decrease in systemic blood pressure, and selective effects of either efferent or afferent glomerular dilation, some degree of preglomerular vasoconstriction, combination of the two. So really that initial reduction of the glomerular pressure is what you may typically see at first as that dip in the EGFR, which is not the dangerous nor in the magnitude is really also the function of the initial EGFR values at which you start. The lower the GFR, the less the dip that tends to occur. But that's oftentimes as one of the reasons for why these drugs are discontinued. Clinically, I continue them if the dip is within 30% of what would be expected. Beyond 30%, you may choose to reduce the dose or stop the drug altogether. And oftentimes with SGLT2 inhibitors, there are some studies that are even suggesting continuing to use them in the case of AKI as well. So to summarize this, we really are now dealing with 4 pillars of therapies, really as tools to allow us to prevent ongoing progression of diabetic kidney disease. And since the institution of the RAS blockade in the 1990s, early 2000s, we've witnessed significant strides in addressing this unmitigated risk associated with diabetic kidney disease progression. We have additional drug classes, which includes the SGLT2 inhibitors, the GLP-1 RAs, the non-steroidal MRAs that are bolstered by a robust body of data and the efficacy of these trials and ongoing studies that go on. And really, it's the responsibility of a team of internal medicine physicians, family medicine physicians, our clinicians, our endocrinologists, our nephrologists, cardiologists, really everyone taking care of the patient, who are encouraged to utilize this pillared approach of diabetic kidney disease management to really guide our framework, going down as low as an eGFR of 20, really. So the take-home point is to screen for diabetic kidney disease, utilizing serum creatinine, cystatin C, urine albumin to creatinine ratio, starting at 5 years after the onset of type 1 diabetes and at the time of diagnosis for patients with type 2 diabetes. SGLT2 inhibitors and ACE inhibitors or ARBs are really first-line agents in patients with diabetes and chronic kidney disease. GLP-1 receptor agonists, non-steroidal MRAs are currently considered based on a risk-based disease-modifying therapy, specifically when we're looking at albuminuria, glycemia, weight loss, and cardiovascular disease. And really, it requires a focused effort of a multi-dimensional team to really assess those risk factors and provide the optimal care for our patients. And with that, I thank you very much and happy to answer any questions.